Welcome back to MBME 26. Today we're going to be covering questions 41 to 50. These videos take a long time to make, so please like and subscribe if you find this helpful. Let's not waste any more time. Question 41. So in this question, we have a 70-year-old man undergoing hip arthroplasty, receives oxycodone and diphenhydramine for the pain and itching. On day 2, he's disoriented, calls the nurse mom, and attempts to climb out of bed saying he has to catch the bus. It happens. Exam inattentive, cannot recite the days of the week backward, oriented only to name, pupils 4 millimeters reactive, no rigidity or clonus, causes out serotonin syndrome there. 126 sodium, 4.1 potassium, creatinine 1. What's the diagnosis? It's going to be delirium. So delirium is an acute medical illness that's seen oftentimes with elderly patients. It's poorly understood, but it's thought to have something to do with acetylcholine states. You have problems with awareness and cognition. You have a baseline that fluctuates in severity over time. You can have visual hallucinations and paranoia. It's not Alzheimer's. It's going to be progressive memory loss, chronic, not abrupt and acute. Serotonin syndrome would be the clonus. That's why we canceled it out. Key encephalopathy, ataxia, thiamine deficiency, and vascular dementia is a stepwise decline after a stroke. So look out for that waxing and waning focus. Triggers UTI, drugs, because it floods your CNS with cytokines and cortisol, neurotransmitter imbalance. If uncorrected, you get false aspiration problems, persistent cognitive decline. Very common in ICU patients, because sleep fragmentation and anticholinergic burden can precipitate delirium. All right, folks, that's delirium. 41. I'm going to make this one really simple. So in this practice question, we have a 22-year-old man, collegiate soccer player, struck in the flank by a knee. 10 minutes later, he collapses with dizziness, got a heart rate 130, blood pressure 82/55. Exam reveals guarding and severe tenderness in the left upper quadrant. There's no external bleeding. Focus abdominal sonography shows free intraperitoneal fluid. Which organ is the source? Now, if you have, this is the dude's belly, blunt trauma like a knee to the belly, on step 1, it's probably going to be the spleen until proven otherwise. That could have abdominal tenderness, and you have to do an exploratory laparotomy to kind of repair this damage. Let's talk about why these are wrong. Descending colon, the fresh, bright red blood from the rectum typically indicates bleeding from the lower gastrointestinal tract. So descending colon, you'd have hematochezia after a seatbelt sign. So your colon injuries usually cause peritonitis from fecal contamination. So it's not going to be rapid hemorrhagic shock. B, the left kidney, gross hematuria, flank ecchymosis. So you have retroperitoneal bleeding, and it seldom produces large intraperitoneal fluid on your fast. C, the liver. There would be right upper quadrant pain at typically your 8 to 11 rib fractures. You have free fluid that can localize around the liver, but it's not primary low upper quadrant. And the pancreas. So that would be epigastric pain, elevated amylase. So pancreatic injuries, they bleed less, and they're probably going to present later with the retroperitoneal fluid. Enzymatic peritonitis. So if you think about the spleen, it sits beneath 9 to 11 ribs. And if you just hit it bluntly, it can cause a capsular laceration, and that'll just release a ton of blood into the peritoneum. You get tachypnic hypotension. And so the hallmarks here are going to be left upper quadrant tenderness, also Kerr sign. It's going to be like shoulder pain from your diaphragmatic irritation, and low ribs through 9 to 11 are fractured. So if he's stable, then you can call an interventional radiologist and they can coil up the splenic artery. But if the vitals are going way down, you just got to get the knife out and go to maybe do a splenectomy or just try to repair it. Post-op, you actually have to do some stuff because if they have no spleen, that means they have no IgM, clearance of your encapsulated bacteria. And so that means we have to do the vaccines, pneumococcus, meningococcus, HIV. And then if they have a fever, they definitely have to get in touch with their physician. So hypotensive soccer player, lower upper quadrant pain, it's going to be the spleen. It's the most vascular, solid organ in that quadrant. And it sits right under, your 9 to 11. All right, there's 42. Moving on to 43. Here we have a 17-year-old high school wrestler presenting with 5 days of exhaustion, low-grade fever, and sore throat. Exam shows palatal petechiae, posterior cervical lymphadenopathy, and palpable 3-centimeter spleen tip below the costal margin. CBC shows leukocytes of 18,800, 12% atypical lymphocytes, serum agglutinate, your horse erythrocytes within minutes. What cell type composes the majority of these atypical lymphocytes? Okay, so there's your practice question right here. I'm not going to show you the answer yet, but I will give you a little bit of a hint. What if they were to say something like CD21 in the question stem? And usually they say sheep, red blood cell, agglutination from your cross-reactive IgMs. Well, that is commonly known as, they don't really say this very much anymore, but the monospot test. And so by now, you're probably thinking about diagnosis. Some other buzzwords you need to know might be atypical Downy cells. That's when we have CD8 positive T cells enlarging, get the skirting while they're attacking the infected B cells. And that's your Downy cells. You could also have drainage from the oropharynx. That's where Epstein-Barr virus enters, posterior cervical nodes. Also, we have another Kerr sign and splenomegaly. So mass proliferation of your T and B cells causes your congested splenic cords, and that can rupture, causing splenomegaly. And also buzzword rash after amoxicillin. So polyclonal B cell activation generates immune complexes that can precipitate a macular papular eruption. This is also associated with Hodgkin lymphoma, nasopharyngeal carcinoma, so latent Epstein-Barr virus, X-linked proliferative disease, so SAP, gene mutations causing fulminant Epstein-Barr virus hepatitis. Also HIV seroconversion syndrome, so it's a mono-like, has a negative heterophile test. And autoimmune hemolytic anemia, so the cold agglutinin IgM agonist. And the pathophys, this guy's a wrestler, but kissing. It's the kissing disease. Epstein's-Barr binds to the CD21, and then you get B cell blasting in your antibody flood, so the heterophile IgM. MHC1 presentation attracts your CD8 positive CTLs, so you get a T cell response and atypical cells. And then the latent Epstein's-Barr virus in memory B cells means that reactivation is possible. And so our answer is indeed going to be C. Now let's look at those trap answers why they're wrong. B lymphocytes. Yes, CD21 is involved. So the CD21 are the targets and they're infected, but they appear normal. So it's not going to be your atypical answer. So A is not correct. B, CD4 positive, those are your IL-2 helpers. They help out with class switching. Not going to become your downy, so not B. D, your FOX, so that's your immune breaks. Those are suppressors, so no. And natural killers, if your MHC1 is missing, it's going to be your Buzzy association with your natural killer cells and your perforin granzyme stuff. So those guys don't have your heterophile links and atypical morphology. So basically how this all works for question 43 is we have Epstein's-Barr virus sneaks in through the saliva and it hijacks CD21 on the naive B cells, and then it pushes them into overdrive. The immune system calls in the big boys, CD8 positive T cells, and those swell up into those famous downy bodies, and then they jam the cervical nodes and the spleen. CD8 swells up downy. Robert Downey Jr., CD8. The powerhouse of the CD8 comes in after the CD21 infection by Epstein-Barr through the saliva. So look out for those posterior cervical nodes, a fever that lingers, and splenomegaly, and also avoid amoxicillin. Unless, of course, you've got that group A strep. All right, for our next question, 44, we've got a 68-year-old, 15-year history of non-alcoholic steatohepatitis presenting after collapsing at home. She is pale and diaphoretic, low BP, bright red blood is pooling, and her exam shows abdominal ascites, spider angioimata, distended veins, so cirrhosis. Endoscopy confirms esophageal varices. Which vascular process most directly produced these varices? So whenever you have a really high portal pressure, like port pressures like, I don't know, greater than 12 mm mercury, one of the sneeze or just like any little increase in pressure like can actually just unleash a half liter of blood. And so your left gastric and azygous portal cable has like the backflow. It's all caused by, you get your cirrhosis of your liver and it obstructs the hepatic sinusoids. You'll just get like a huge spike and the blood will detour through the left gastric vein tributaries up the esophageal submucosa and it drains into the esophagus system. And so the veins, they balloon into these like fragile varices. You get wall tension. And so coughing, sneezing, vomiting, or if you have like an NG tube insertion, then it can rupture that. And that can cause your brisk GI bleed, and then that puts you in hypovolemic shock. So definitely for this, you have to look out for the associations of painless bleeding. Also palmar erythema and spina nevi. That's a failure of your estrogen metabolism. High-pitched bruit at the umbilicus. That would be if you had large caput medusae. Labs would show low platelets. So yeah, portal hypertension diverts blood away from the fibrotic liver, most significant being the left gastric azygous junction at the lower esophagus, where increased flow dilates the submucosal veins through varices and ruptures. Okay, anastomosis between superior and inferior. These wouldn't form there, so no. Direct erosion of the thoracic aorta. That'd be like a aortoesophageal fistula. That's a Chiari triad. Super rare aneurysmal catastrophe. It's unrelated to portal hypertension. Chronic reflux, so Barrett's esophagitis with submucosal ulceration. That's like Barrett's metaplasia. That causes micro ulcers, not large volume like bleeding and varices. E, portal blood shunted from para-umbilical to superior epigastric veins. That's caput medusae. So it gives your abdominal wall collaterals, not your esophageal stuff. And now, just so you guys know, it's like 1 in 5 patients with cirrhosis will suffer your variceal bleed. And then it's like 1 in 3 will die within 6 weeks if you don't act really quickly. So it's that scarring will bottleneck the portal inflow, and that cranks up the pressure super high. And the easiest escape is going upwards through the left gastric vein. And that blood will just slam right into the systemic azygous highway lining, the distal esophagus, and that balloons your submucosal channels. So like the really thin walls there can just explode whenever you get a cough or a sneeze. So painless, bright red, metamesis, hypotension. You also have the stigmata of your chronic liver disease, so spider angiomas or angiomatas. That's just like saying like an abnormal growth that's produced by the dilation and new formation of blood vessels, and also palmar erythema, CDs. You can also give non-selective beta blockers to try to help out. Sometimes you got to give octreotide really in short-acting scenarios, more acute, to clamp the splanchnic flow, and then endoscopic band ligation as well. But the big thing here is that you have to know the left gastric to azygous retro flow is going to be one of the varices. All right, question 45 of MBME 26, section 2. We have a 9-year-old girl. She's got Becker's muscular dystrophy, hospitalized, intractable vomiting. She has not kept food down. Got all this stuff on exam, that low lactate, markedly elevated ketones, low glucose in the urine, ketones +4. Now the question is, which hepatic pathway is currently supplying the brain's energy? Well, we have the ketone bodies, right? And so this is kind of an easier question. It's going to be B, carnitine shuttles, because that's just beta oxidation is what causes this. Cahill cycle, I'll explain these really briefly. That's your alanine glucose cycle. So it's the exercise nitrogen dump. It gives you short-term gluconeogenesis, but it's not going to meet the metabolic needs of the brain at all, especially once your muscle catabolism slows down. So just think of that one for like alanine glucose. Okay. Wrong answer. C, the Cori cycle, that's the lactate shuttling. So that's active in sprinting muscle or hypoxia, and that would raise the serum lactate. So not quite. D, tricarboxylic acid, citric acid cycle. That's like your pyruvate ATP factory. It still runs, but the substrate is now acetyl-CoA from the ketone catabolism in the brain. It's not the liver's primary export, so not the right answer. And then E, urea cycle. So that's your ammonia detox center. And that does prevent hyperammonia, but that does not produce any calories. So that's the wrong answer. And that's the end of 45. Okay, next question is 46. Here we have a 38-year-old woman, 6 months of exertional dyspnea and fatigue. She has bled from her nose, epistaxis since grade school, recently required iron tablets, a lot of bleeding, I guess. Examination shows 95% on room air, multiple bright red lesions on her tongue and the blanching with pressure. Contrast reveals micro bubbles in the left atrium, 3 cardiac cycles after intravenous injection. What abnormality is best explaining her hypoxia? All right, so that delayed bubbling does tell you have a right to left shunt and the mucosal telangiectasia. That does point you toward pulmonary AVMs. So here's the pathophysiology of hereditary hemorrhagic telangiectasia. It's just a bad allele in your TGF beta pathway, and this erases your normal capillary beds. So they're just absent. And so the arteries just dump into the veins, no arterioles. And so on the skin, you get the red dot, and in the lungs, it's like a shunt. And it steals the oxygen, and it skips the filter that normally traps the clots and bacteria. And so you get hypoxemia that barely changes at all with oxygen, and a pathway now you have for a paradoxical stroke. And you look out for those lifelong nosebleeds because of that right to left shunting, the blanching on the mucosa, iron deficiency anemia, and the clubbing because of the hypoxemia. And then the bubble echo that lights up in the left atrium after just a short amount of time, definitely is going to kind of tell you that there's this intrapulmonary shunt. So we got this woman with epistaxis, nosebleeds since childhood, tongue, telangiectasias, clubbing, late arriving echo bubbles. So like if it takes a while to get there, then the bubbles should also make you think of pulmonary arteriovenous malformations. So it's that TGF beta mutation, autosomal dominant, where you get the AVM that bypasses the capillary filter, letting the emboli slip into the systemic arteries. That's the shunting, folks. All right, so here's our practice question. Moving on to 47. 58-year-old man, he has Crohn's, underwent ileocecal resection 6 months ago. Now he has high output ileostomy. The past week, he's felt fatigued. Labs, the labs here. Arterial blood gas, 7.3. Which acid base disorder describes this guy's status? So ileum is diverted to an artificial opening in the abdominal wall. And so actually each liter of your ileostomy fluid that's carried away is enough to neutralize a full tablet of antacid. So if you lose 2 liters, then your blood is just going to be super duper acidic. So we have hypercholoremic metabolic acidosis. It's when bicarbonate exits via the guts or the renal tube, and the body keeps its electrolyte balance by hoarding chloride. And so then the medulla is going to order faster breathing, and for every tiny little modicum of bicarbonate loss, the PaCO2 should fall about 1.2 millimeters mercury. And that's going to be Winter's formula. So we have the bicarb at 15, the predicted PaCO2 is 30, measured 29. So pH is still low, so it's going to be partially compensated. Basically, what you look out for on test day, here's kind of the math for it, is you have diarrhea, pancreatic fistula, ileostomy, renal tubular acidosis, non-anion gap. acidosis is what you think of. So you just got to run the anion gap and apply Winter's formula, and then you'll get the diagnosis. So here are the trap answers, why they're wrong. Gap is normal, so it's not A. Uncompensated, same gap, it's not B. C, respiratory alkalosis. Well, the pH, look at it. Non-gap acidosis, uncompensated. And then here's the pathophys. Bicarb loss, plasma is preserved by the chloride, so you lose that bicarbonate, drops the blood pH. Then we have hyperventilation. Kidneys enhance the ammonium and the titratable acid, generating new bicarbs that it can't catch up. It's only partially compensated. All right, question 48. So let's just dive right into this practice question. 70-year-old woman, newly diagnosed IgA multiple myeloma. Nice they tell you that. They could have just given you calcium or IgG. But yeah, they begin a combination therapy that includes reversible 26S proteasome inhibitor. 48 hours later, repeat exam shows rising potassium, phosphate, and uric acid levels, which intracellular change in the malignant plasma cells best explains this rapid shift. Now, before we answer this, I just want to say a little factoid about multiple myeloma. The average myeloma cell produces more protein per minute than any other cancer cell. If we turn off the garbage disposal, so to speak, and your body self-destructs. So proteasome inhibitors, bortezomib, what it does is it slips onto this 26S proteasome, and then it freezes the blade. It's like the garbage disposal. It freezes it. And that will leave your immunoglobulin fragments all around. They're going to be sticking all over the place. And so then within hours of your unfolded protein event happening, you have the caspases that slice open your mitochondria, and the plasma cells just implode, and they dump potassium, phosphate, and purines into the bloodstream. And that is what we call tumor lysis syndrome. There's another question in the word bank where they're just all elevated. So for that, you got to hydrate and give allopurinol. And so a patient with myeloma starts a proteasome blocker, then the labs will just go crazy. So it's the accumulation of your ubiquitinated misfolded proteins that are going to target your apoptosis. Cyclin D1, the G1 arrest, that's going to pertain to your CDK4/6 inhibitors, not proteasome blockades. So nope. DNA double-strand break repair. So that's your PARP trapping. That's a mechanism of PARIB. It's relevant for this question. Intracellular calcium release from the ryanodine receptors. Calcium surge, yeah. RYR leak. So that's going to be malignant hyperthermia, though, and digoxin toxicity. So that's kind of a different mechanism. Amylase synthase activity impairing DNA. So that's the 5-FU effect that targets your DNA synthesis in solid tumors, not the plasma cells. So that's not going to be the right answer for this question. So the key stuff here is you have the proteasome inhibitors, and they block the degradation of your ubiquitin tag proteins. So you get that massive cell death. And then, tumor lysis syndrome. Cool beans. All right, 49, two more. Here we have a 52-year-old female who quit smoking last year and visits because of a 3-week history of sticky dark fluid staining her bra and a rubbery bump just inferior to the left nipple. She denies fever, trauma, cyclical breast pain. Exam has a 1.2 centimeter poorly defined subareolar mass with mild tenderness, no skin erythema. Mammogram shows branching densities under the areola without speculation. Core biopsy reveals a markedly dilated duct lined by intact epithelium, surrounded by lymphocytes, plasma cells, and numerous lipid-laden macrophages, no atypia. Which diagnosis best fits? And the answer is going to be B, mammary duct ectasia. So not every ominous nipple discharge is going to be cancerous. And ectasia just refers to dilation or abnormal widening of the tubular structures of the body. So we have declining estrogen, and it thickens the major lactiferous duct plugs, and it dilates and leaks fat. So the plasma cells just swarm, and the macrophages start to drink up the lipids. And then the fibrosis will tug the nipple inward. And so on mammogram, the subareolar branches are going to mimic carcinoma. But on the biopsy, you see no atypia, just foamy macrophages and chronic inflammation. And then clinically, you got that green and brown discharge, the periareolar tenderness. And then typically it's going to be like a 50-something smoker. So you just reassure them, give warm compress and excision only if the symptoms persist or the imaging says that it's suspicious. This is just a dilated duct, plasma cell infiltrate. But we have to be able to rule out these other answers here. So acute mastitis, so that'd be a red breast and lactation. That requires erythema and also systemic signs, so not quite. Fibroadenoma, that's going to be like a 25-year-old mobile marble, kind of well-circumscribed rubbery, not subareolar. Intraductal papilloma, that's the bloody unilateral discharge, so the papillary fronds with your fibrovascular core, not lipid. Fibroblastic. Invasive ductal carcinoma. That'd be a hard rock-like mass that's speculated on your mammogram. That shows your malignant cells that invade the stroma. So here, the majority of cases, it's like 90% are going to have thick, green, brown discharge. And it's poorly circumscribed periareolar mass that's tender. The subareolar branching density, it's just basically you get the dilated duct and the plasma cells and the foamy macrophages. Usually it's just going to resolve with warm compresses. And that's it. That's 49. Last question, 50. Now, this is just like a huge memorization question, but what you have to know is the patent ductus arteriosus, that's the machine-like murmur, kind of systolic. They're going to find new ways to ask you this because that's too easy and pathognomonic. But one of the ways that they can ask you is the embryologic origin of that anomaly. And you think of, you get the 1, 2, usually they'll ask about the 4, 5, and 6, and you have to decide, hey, which of these arches is associated with which thing? And PDA is always associated with 6. You should have memorized that. There's no way around it. Patent ductus arteriosus is from the left, 6th aortic arch. There's your memory. Beautiful thing. Prostaglandin E2 keeps it open. NSAIDs closes PGO2 after birth. Keep the closure. It said decreased PGO2 after birth. So yeah, like I said, the machine-like murmur, preterm infant worsening to tachypnea. Indomethacin turns the murmur off. NSAIDs, they block that COX, lowering PG2. Then it causes the constriction. Differential cyanosis, reversal can happen. Associations, maternal rubella, higher PDA incidence. High altitude birth because of that persistent PGE2, because of that altitude keeps that open. Congenital heart lesions needing PDA to survive. Prostaglandin infusion. Left recurrent laryngeal nerve. So it's that 6th left aortic arch, forms the ductus arteriosus and proximal left pulmonary artery, and it can cause the shunt reversal eventually. So here is your practice question. Look at all these arches. The answer we already know is E, and there's a continuous murmur. They're just saying, hey, which does it arise from? But what we need to know is why the other ones are wrong. All right, so this first one is maxillary artery. So that supplies your face, just totally unrelated here. The second arch is the stapedial hyoid. It's the tiny neck vessels. Not the fourth is the part of the aortic arch. And the fifth, that's just kind of nothing. There's not really anything there. Like rudimentary, it's just going to kind of go away. It's just gone, you know? Nothing really for 5. But these are the ones you have to know. Maxilla, stapedial hyoid, aortic arch, and the right subclavian. And then PDA is 6. They always ask about PDA for some reason. I've seen also maxilla and stapedius, but I digress. So typically it's the inflation of the alveoli and the oxygen climbing, the PG plummeting that causes this to shut. But if you have a preemie baby, then they're not primed for that. So we have to give them indomethacin to turn off the COX, dropping the PGE, causing the ductus to snap closed. So that left 6th arch, ductus arteriosus, and that, my friends, is the end of this little series, MBME section 2, 41 to 50. Again, these questions are my own. Definitely go and do MBME 26 for yourself. I'm just helping you, or everything that you should know by the time you finish MBME 26. Next time, we'll be covering section 3, questions 1 through 10. If you're into that, then like and subscribe for more content. We'll see you guys on the flippity flip.